Hello and welcome. Today we're doing something a little different. We're going to step right into a consultant viva exam and break down one of surgery's most classic problems, the adrenal incidentaloma. So whether you're actually prepping for an exam or you just want to sharpen your surgical decision-making, this one's for you. Let's get started.
Okay, thank you, examiner. I'd start, as always, with a thorough history and a very focused physical examination. And I've really got two main goals here. First, I need to figure out if this mass is hormonally active, if it's functional. And second, I'm looking for any clues that might point towards malignancy. So, here's how I'm going to tackle this. I'll begin by detailing the history and physical exam, really digging for those clinical clues. From there, I'll build out a comprehensive differential diagnosis. After that, I'll lay out a logical, stepwise investigation plan to nail down the diagnosis. And finally, I'll discuss the definitive management, which of course will depend entirely on what those investigations show us.
Right. So my whole approach to the history and exam is driven by those two big questions. Is it functional, and could it be cancer? Every single question I ask and every part of the exam is aimed at getting closer to those answers.
My number one priority, right off the bat, is to screen for a functional tumor. I need to know if we're dealing with a hormonally active lesion. So I'm going to systematically ask questions to screen for the big three syndromes: Cushing's, Pheochromocytoma, and Conn's. A structured approach here is key so that nothing critical gets missed.
So first up, I'm thinking about Cushing's syndrome, which is all about excess cortisol. I'd be asking the patient things like, have you noticed any unintentional weight gain, especially in your face or around your midsection? I'd also ask about skin changes, are you bruising really easily, or have you noticed any new deep purple stretch marks? And of course, I'd ask about any new diagnosis of high blood pressure or diabetes, because those are classic red flags for too much cortisol.
Next, and honestly this is the most important one, I would screen for a pheochromocytoma. This is the one diagnosis you absolutely cannot afford to miss before an operation. It can be life-threatening. I always use the 5 Ps mnemonic to remember the key questions. Have you had spells of palpitations, where your heart feels like it's racing? What about pounding headaches, the pain? Any episodes of drenching sweats or perspiration? Has anyone ever told you that you look very pale during one of these spells? And finally, any strange feelings like pins and needles or paresthesia?
And to finish up the functional screening, I'm looking for Conn's syndrome, or excess aldosterone. I'd ask about high blood pressure, and specifically if it's been really tough to control, even with several medications. I'd also ask about symptoms that suggest low potassium, like muscle weakness or cramping, and about being excessively thirsty or having to urinate a lot. Once I've covered the functional aspect, then I'd move on to ask about things like weight loss, fevers, and any personal or family history of cancer or other endocrine problems.
Okay. So once I've gathered all that information from the history and physical exam, the next logical step is to formulate a really broad differential diagnosis for this 4-centimeter adrenal mass. I find it really helpful to put the possibilities into categories to make sure my thinking is organized and I don't miss anything.
So my differential would look something like this. Under the functional category, we've got the big three we just screened for: pheochromocytoma, Cushing's adenoma, and an aldosteronoma. Then in the non-functional but benign bucket, the most common by far is a simple non-functional adenoma. But you also have to think about things like a myelolipoma, a cyst, or even a hematoma. For primary malignancies, the big worry is an adrenocortical carcinoma, especially with a mass this size. And of course, we have to consider secondary malignancies, meaning a metastasis from somewhere else, like the kidney, lung, or breast. And just to be complete, I'd throw in a rare infectious cause, like adrenal TB.
Very good. How would you investigate this patient? Thank you. My investigation plan would be very logical and stepwise. We'd start with simple biochemical tests and then move on to more complex imaging and confirmatory studies as needed. The order here is absolutely critical. We always start with the biochemical screening to figure out if the tumor is functional. It's only after we have those results, either ruling out a functional tumor or confirming one, that we really dig into the details of the imaging. This sequence is all about safety. It prevents catastrophic mistakes, like accidentally sticking a needle into an unsuspected pheochromocytoma.
Okay, for step 1, the biochemical screen, here's the panel of tests I'd order for every patient. To screen for a pheochromocytoma, I'd get plasma-free metanephrines. For Cushing's syndrome, the go-to initial test is the overnight 1 mg dexamethasone suppression test. For Conn's syndrome, I'd order plasma aldosterone and renin levels so I can calculate the ratio.
And of course, I'd get some baseline labs like a CBC and electrolytes, paying close attention to the potassium level.
Now, it's super important to note that if any of those screening tests come back positive, we aren't done yet. The next move is a confirmatory test, which is more specific and helps us avoid acting on a false positive. So, for example, if the plasma metanephrines were high, suggesting a pheo, I would then order a 24-hour urine collection to measure total catecholamines and metanephrines to confirm it. It's that second step that really solidifies the diagnosis.
Excellent. Let's say your tests confirm a 4-centimeter pheochromocytoma. Outline your management. Okay, this is probably the most critical management pathway in all of endocrine surgery. The entire plan for a confirmed pheochromocytoma is built around incredibly careful preoperative preparation. Patient safety during the operation is everything.
So the management plan starts with medical optimization, which usually takes about 2 weeks. The crucial first step, and you can't get this wrong, is to start an alpha blocker, like phenexybenzamine. We start them on a low dose and slowly increase it until their blood pressure is nicely controlled. Only after we've achieved a good alpha blockade do we then add in a beta blocker, like metoprolol, to handle any fast heart rate. And here's the massive red flag. You never start with a beta blocker by itself. That leads to what's called unopposed alpha stimulation and can trigger a massive hypertensive crisis. It's a classic exam pitfall. Lastly, we make sure the patient is well hydrated before surgery.
Once we're in the operating room, it's all about teamwork with an experienced anesthetist. We'll need advanced monitoring for sure, an arterial line for real-time blood pressure, and a central line. The anesthesia team has to avoid any drugs that might provoke the tumor to release catecholamines. From a surgical standpoint, the goal is to handle the tumor as little as possible. And the single most important step of the operation is to get control of the adrenal vein early. You want to ligate that vein first before you start manipulating the tumor itself. This traps all those hormones in the gland instead of letting them flood into the body.
You also have to be ready for the 2 big, predictable blood pressure swings. While we're handling the tumor, before that vein is tied off, we fully expect the blood pressure to skyrocket. The anesthetist will be ready with powerful, short-acting drugs like nitroprusside to control it. Then, the very second we ligate that vein, the exact opposite happens. The body is suddenly starved of all those catecholamines, and the blood pressure can plummet. We anticipate this and are ready to hit them hard with IV fluids and vasopressors like noradrenaline to bring it back up.
All right, let's just step out of the role play for a second. As you can hopefully see, acing this kind of scenario isn't about knowing one tiny, obscure fact. It's about demonstrating to the examiner that you have a safe, logical, and repeatable system for dealing with a complex problem. Let's break down what really makes for a successful answer.
So what's the winning formula? Well, it really boils down to a few core principles. You have to start with a clear structure. Tell the examiner your plan from the get-go. Always prioritize safety, which in this case means you always think about and screen for a pheo first. You have to verbalize your thought process so the examiner knows why you're making certain decisions. A great candidate anticipates the next question, like what to do about complications. And finally, you have to know those non-negotiable critical steps cold, like alpha before beta and ligate the vein first. Showing you can stay calm and systematic is what they're really looking for.
And to leave you with one final thing to chew on, let's think about the next challenge. The surgery's over, it was a success, but now the patient is in the recovery unit, and their blood pressure is dangerously low and not responding well to fluids and pressors. What's on your differential now? And what's your immediate next move? It's thinking through these kinds of what next problems that really separates a good candidate from a great one.